Welcome to the presentation of the Mizzou Victorious Teams Clarion competition presentation. This is really quite a treat to be able to say victorious team, in there. I'm Dr. Myra from the School of Nursing, and I'm one of the faculty who were in the background cheering them on. Sue Bourne is here. My other colleagues are Dr. Chris Hagelin and Dr. Amanda Alman. We didn't have a lot to do, did we, Sue? We just sort of were the cheering section for these. But who I really want to introduce you to today are the members of the victorious team, Scott and Terri and Sabrina and Kaci. And together, they took a complicated case provided by the Clarion competition organizers, did the analysis, went to Minneapolis, presented their analysis and recommendations for a solution to a complex case with implications for patient safety and quality of practice to a panel of judges, and brought home the first place honors. Now, what can I say? Just really great stuff. Clarion began just as a local competition in Minneapolis at University of Minnesota, but in 2005 it went national, with universities sending teams, one team per university. The team always includes someone from medicine and someone from nursing. The other two team members, and it's always a 4-member team, are from allied health professions. This year, from public health and from health management informatics for us, which I think was a very great matchup given this case. So the team has done their work, the presentation has happened, and I need to sit down and give the microphone to them because that's who you want to hear from. Who starts? Okay, this is Terri.
Hi, and welcome. Thank you so much for coming today to hear our presentation. So over the next 20 minutes, our interprofessional team is going to present to you our recommendations for reducing COPD readmissions to our local hospital. We were given a fictitious hospital in Ohio called Odinia. We were given a case study, as were the other 9 universities. One dropped out. 9 universities, and we were given roles as from nursing, medicine, and throughout the hospital. We were given 4 case scenarios of situations within the hospital of how the patients were having their care delivered. So out of that, we were given the opportunity to develop what you're going to see today. We were given 20 minutes to present this. We had to be equal among ourselves. Then we presented this in front of a panel of judges of senior health executives from across the country once. Then we got to the top 4, and we did it again that afternoon. And they kept adding more judges, and we kept getting more nervous as we went. We were like, how many more? But it was a wonderful experience, wonderful team members. We've really grown together. It's been a lot of work, but it's been worth it. So the Clarion is a wonderful organization. So we're going to start our presentation now. So we're going to present to you today our recommendations and plan for COPD readmission reduction strategies. Here's an overview of our presentation. We're going to introduce the problem, give you a root cause analysis, our recommended interventions, a financial analysis, and then our conclusions. So why are we here today? It has been noted by our Chief Executive Officer that we have a 25% readmission rate in our community hospital, Odinia in Ohio, for COPD readmissions. So we've come up with to recommend interventions to reduce the 30-day readmission rate. COPD stands for chronic obstructive pulmonary disease. It's the 4th leading cause of death in the United States, and by 2030, it's predicted to be the 3rd. It's a public health global problem. 50% of all COPD readmissions are avoidable through care transitions. The U.S. Affordable Care Act of 2010 has put forth to CMS, which is the Centers for Medicare and Medicaid, cuts to certain diagnoses. Right now, hospitals are being penalized for increased readmissions for pneumonia, acute MI, and CHF, which is congestive heart failure. It is predicted that COPD will be one of those next selected conditions. Thus, we are recommending these interventions to decrease our chances of being penalized for our excess readmission rate here at Odenia Community Hospital. Of course, readmissions negatively impact patient health as well as the family. Some statistics about our community hospital. Like I stated, we have a 25% COPD 30-day readmission rate. The national average is 21%. As we looked at the cases and the patients coming through the emergency department, 10% of those have a COPD diagnosis, with 15% of all admissions to our hospital having a pulmonary diagnosis. Now, there are national COPD guidelines called the GOLD guidelines, and that stands for Global Initiative of Obstructive Lung Disease. As we looked at what was being done, we were finding, and we'll talk more about that, that the guidelines are not being followed here at our community hospital. So our aim statement is to reduce the COPD 30-day readmission rate from 25% to 20% within 1 year through the implementation of our recommended interventions. So this slide illustrates the COPD cycle. Currently, this is what the patient's experiencing here at our hospital. You'll see that the purple lines are the exacerbation or the flare of the disease when the patient's having more trouble breathing. And the green lines are the readmissions. So as you can see, we're having the time span between these are very short. We're having frequent exacerbations along with frequent hospital readmissions. That's our current state. What we want to see for the future is this. We know we can't make this a 0% because this is a very severe disease. But what we want to see is that through our interventions today, we're going to expand the time frame between hospital admissions and improve the quality of life for the patient and family. So now I'm going to pass it over to Sabrina, and she's going to talk about our root cause analysis.
All right, so I'll go into our root cause analysis now, which we applied to identify contributing factors to COPD 30-day readmissions. Our first step here was to create the fishbone diagram that you see on the slide, and the way that we constructed this diagram is we did a general review of the literature to identify problems that contribute to those COPD 30-day readmissions. We came up with 4 main categories, which include patient factors, provider factors, system factors, and hospital factors, all of which contribute to those readmissions. Looking at patient factors, we found things such as underutilization of primary care physicians, and we found that patients often lack the education to fully understand and manage their disease. Looking at provider factors, we found things such as poor communication between providers as well as lack of adherence to those GOLD guidelines. Systems factors included things such as lack of an integrated electronic health record system, fragmented care, poor transitions of care, and finally looking at hospital factors that contribute to 30-day readmissions, we found that there's often poor follow-up with the patient as well as poor discharge planning. So the next step was to use the cause mapping method that you see here, and this is different from the fishbone because we really looked at specific details of the case. The cause map is used to identify cause and effect relationships, and as you see there are 3 red boxes here on the left side. Those are the hospital goals, which include functional status, quality of life, and efficient use of resources. And these goals are what are negatively impacted by COPD 30-day readmissions. Now this chart is read opposite from the fishbone. It's read from right to left, so I'll just walk you through one example in case you're not familiar with this methodology. We'll start in the upper right-hand corner with the lack of health literacy. Low health literacy can impact a patient's ability to self-monitor. A lack of self-monitoring in turn can result in poor patient adherence to their treatment plan. This can negatively impact their functional status and ultimately result in the patient being readmitted to the hospital. So now that we've identified the root cause of COPD 30-day readmissions in the hospital, I'll go on to discuss some solutions to address those problems. On the right side of the screen here, you see a 2x2 diagram, and this is what we use to compare the relative impact of our considered recommendations, numbers 1 through 10 on the left, with the relative resources required to implement those interventions. So based on our analyses, we recommend implementing those interventions which have the highest impact. In other words, those that fall in the top 2 quadrants of the 2x2 diagram. These interventions are the ones that are bolded in green, and they include hospital factors such as hiring a discharge advocate and implementing in-home monitoring, provider factors such as ensuring physicians are adhering to the COPD GOLD guidelines, And finally, systems factors, including creating a COPD admission order set, using or adopting an electronic health record in the community, and using the Lean Six Sigma team that is currently in place here in the hospital throughout the implementation of our recommendations. So returning to the cause map one more time, like I said, it can be used to identify specific cause and effect relationships, but it's also very useful for identifying potential points of intervention. So those green boxes are the interventions that I just introduced to you in the previous slide, and that's what we've added onto the map that's different from the one that I showed you before. So I'll just walk you through how those solutions match up to the problems that we were able to identify. Poor patient adherence to treatment plan, that can be improved by hiring a discharge advocate. Lack of self-monitoring can be addressed by implementing in-home monitoring. Poor ongoing patient-provider communication can be enhanced through adopting the electronic health record system within the community. Non-standardized practices can be improved by using the Lean Six Sigma team throughout the implementation of our recommendations. And finally, variance in care orders can be improved by creating the COPD admission order sets and ensuring that physicians adhere to the GOLD guidelines. So I'll hand it over to Scott to give you more details about our interventions.
So we realized how difficult it would be both financially and logistically to start all of these recommendations at the same time. And so that's why we actually recommend breaking these down into 3 distinct phases. And as you can see, the Lean and Six Sigma process is actually involved in all 3 phases. We'll talk about why that's important in the next slide. Specific to phase 1, however, we first recommend hiring a discharge advocate. We also recommend following the GOLD COPD guidelines and making admission order sets used for each COPD admission. In phase 2, along with the Lean and Six Sigma process, we also recommend starting the process of in-home monitoring. And finally, in phase 3, we also suggest integrating the electronic health record. So our first intervention to discuss is this Lean and Six Sigma process. And as I just mentioned, this is actually will span across all 3 phases and will serve as the foundation for both the design and the implementation of our recommended interventions. Now, the hospital currently already has a Lean and Six Sigma team and process in place, and they've been successfully working on things such as streamlining the registration flow. But we would have them specifically focus on the COPD discharge process and really help us to design and implement the recommendations that we'll be talking about over the next several minutes. We believe by doing this, it will help us to identify any deficiencies in our recommendations and will also improve both the efficiency and cost effectiveness of the entire system. So moving on now, specific to phase 1, we first recommend hiring 1 full-time nurse that will function as a discharge advocate from the time of admission all the way up until and even beyond the time of discharge. We recommend that the advocate focus on education, communication, and discharge planning with both the patient and the patient's medical team. We recommend that this be done by utilizing a discharge checklist, which can be found in the appendix that we included for the judges to view. So on this checklist are, of course, several different items, but just to give you all an example of what this might include, the advocate would make sure that every patient knows how to properly use all of their medicines, that every patient knows and is set up with the appropriate follow-up appointments. We also recommend that the discharge advocate utilize what's known as a LACE index to really help identify patients that are at higher risk for readmission. This is important in the event that the advocate's time is limited. He or she can then really focus on the patients who need help the most. And so this LACE index is an acronym. It stands for the length of stay, the acuity of the admission, the number of comorbidities, and the number of ER visits within the last 6 months. And by using these 4 components, we can actually come up with a score that can help stratify patients as to the risk for being readmitted. As I said, the advocate can look at this and take this into consideration when deciding which patients to spend, which amount of time with. So still in phase 1, we also recommend following the GOLD COPD guidelines, which are national evidence-based guidelines for COPD management. Certain components of these guidelines, such as smoking cessation and yearly influenza vaccines, have been proven to reduce both mortality and morbidity, as well as the total number of readmissions altogether. We suggest that these guidelines be included in the discharge checklist, and the advocate will then be responsible for making sure they get completed. By doing this, we will ensure that our patients are treated with the most evidence-based medicine. We also recommend making admission order sets to be used for each patient who comes in with this diagnosis of COPD exacerbation. To do this, we suggest creating an interprofessional team composed of the pulmonologist that's in town, one of the primary care providers, one of the ER doctors, as well as a respiratory therapist, a social worker, and one of the floor nurses. And so this team will get together, we'll look at the most evidence-based current guidelines, and really devise and come up with admission order sets that can be used each time a patient comes in with a COPD exacerbation. Now the data on these COPD order sets in itself is pretty limited, but congestive heart failure and pneumonia order sets have been well studied, and both have been proven to reduce mortality, morbidity, the cost of the entire hospitalization, as well as the number of readmissions altogether. And that's why we're here today. And we suspect that if it worked for these other two diagnoses, that would also work for COPD as well. So moving on now to phase 2, we next recommend starting the process of in-home monitoring, and specifically using what's known as the Health Buddy system. So this Health Buddy system is a daily monitoring system that can be made specific for COPD patients. So essentially what happens is a patient will have this little handheld electronic device at their home. And there's a component that the patient can interface with this device, and their vital signs can also be measured. And this data can then be sent back to the discharge advocate at the hospital, who can interpret this data and decide if any further interventions should be necessary. So as I said, this will help integrate symptoms with vital signs, and will also provide significant education and health coaching as well. The other great news is the potential cost for this could be covered for Medicare patients through what's known as a Community-Based Care Transition CMS grant. So just to kind of show you what this would look like, on the left here is the patient interface. This is kind of where the patient interacts with the device. And coming off of this would be things like a blood pressure cuff, and as you can see here, a pulse oximeter. So the patient would put this on their finger, the data would then be sent back to this machine with the oxygen saturation measured, would then send to the discharge advocate, who would be responsible for interpreting this data and deciding what else should be done if the patient is in need or help of something else. So let's walk through an example together of what this might look like. So as a patient myself, in the past 24 hours, have I taken all of my COPD medicines as prescribed? Well, no, I really haven't. So in that case, I would push no. Well, tell us why. Well, I forgot if I was supposed to take this pill once a day or 3 times a day, so I just got really worried and didn't take it at all. So in that case, I would push 2. This would then be sent back to the discharge advocate, who would, of course, become alarmed at this, would then call me to instruct me on the proper way to take my medicines and hopefully prevent me from being readmitted to the hospital, which is our whole goal today. And with that, I will turn it over to Kaci, who will talk about phase 3.
All right, so our final phase here, we recommend that Odenia integrate all of their patient health records throughout the entire community. In order to do this, we recommend that they use the Ohio Health Information Partnership, or CliniSync program. This is a federally funded program that allows communities and statewide entities to view their patients' information on a single network without having to overhaul each individual EHR system within each clinic or hospital. So this can really integrate providers, hospitals, and clinics in the area, and it really allows providers to follow their patients throughout their entire continuum of care. So the benefits to this, aside from, like I said, not needing to overhaul all of their EHR systems, which is incredibly costly, it also increases communications, lessens the gaps in care, and improves coordinations with the PCPs, which is extremely important for chronically ill patients, especially those with COPD. So here's a timeline, just giving you a demonstration of what we think is a realistic timeline to implement all of our interventions. As you can see, it's broken up into our 3 phases, and the Lean Six Sigma does follow throughout. We feel that this is a very realistic timeline to set for the organization. So after going through all of our interventions, we really wanted to make sure that we were addressing the IOM 6 aims, which are to provide safe, effective, efficient, timely, equitable, and patient-centered care. We wanted to have a visual to show you how each of our interventions are really following each of these 6 aims and how they specifically address those. This will ensure that we're not only providing the best care to our patients, but also following evidence-based practices. So finally, I'll go into a financial analysis and give you some information on what we've come up with here. So before we get into it, we wanted to give you some financial assumptions, and the judges actually have in their appendix, they would have had all of the calculations that we did for all of this. So this is kind of a brief version of what they had in the appendix. So based on our data that we got from the case, we assume that there will be 419 Medicare COPD patients per year. For the purposes of this, we have kept Medicare COPD reimbursements, the Odenia readmission rate, and the national average for COPD readmission rates constant over a 3-year period in order to do this financial analysis. Our savings are extrapolated from literature and studies that have been done in similar situations. And finally, our costs are based on our volume assumptions and the literature reviews that we've done. So what's at risk? Why are we here? The point of this is not only to provide better care to our patients and make sure that they are receiving the best care and managing their COPD in the best way possible, but we also want to avoid any potential cuts from CMS should they include COPD in their 30-day readmission policy. So what we've done here is broken down specifically the risk for COPD reimbursements. So for the first year, we expect, based on their high level of readmissions, that they would reach that penalty, the maximum penalty of 1%, which would result in reductions to COPD readmissions, or excuse me, what am I trying to say? Reimbursements, I'm sorry, to about $74,000. For the second year, again, reaching that maximum, they would get dinged about $148,000. And for the third year, again, reaching that 3% maximum, they would get reduced about $222,000. Over a 3-year period, that's a loss of almost $444,000, and that's just specifically for COPD. That's not taking into account the other reductions they would receive should they have excess readmissions for CHF, AMI, or pneumonia. So here's just a financial overview. Next, we wanted to make sure that our interventions were feasible financially for the organization and with what they were dealing with currently. So this is just a broad overview to show you that we are a healthy organization, we're stable, and we are able to take on the cost burden for some of these interventions to reap the benefits for our patients. So our operating income and net assets have increased over the past year. We have a healthy amount of cash. Our key financial ratios there at the bottom, again, just demonstrate that we're in a solid position to take on these interventions and really do them effectively. So here's a cost-benefit analysis, and again, the judges had all of these calculations in their appendix. I'm not going to go through all of these today, but I did want to highlight a few key points here. For the discharge advocate here at the top, the majority of the costs would come from the personnel costs from hiring that nurse to take on these patients. Based on research that we've done, the potential savings of that could be up to $410 per patient per year. For our, let's see here, in-home monitoring system, the cost to Medicare patients specifically would be about $644,000. Now, if we were awarded that CMS grant, the cost of that would be covered. So there is potential here that that cost could actually be zero for Medicare patients specifically. Again, based on research and other in-home monitoring devices and systems that we've seen, we can expect savings of up to $884 per patient per year. And at the bottom here, we have our EHR integration. And now this has zero initial cost. I know that's shocking, but yes. This is a federally funded program, and part of the grant that they received is that they can actually pay to implement this network in all of the clinics, all of the hospitals, and within the physician facilities that they're using. So they actually cover the cost of that. It's a 6-step process to get this network up and running within a community, and they have the funds to cover the cost for that. There are fees that will be assessed to the hospital once that is live, and then later on in the future, during their later phases, there will also be some small fees, $25 per physician per year, which really isn't bad. So adding that onto the charge for the hospital, it's still very cost effective, and it's obviously much cheaper than overhauling everyone's EHR system to try and get everyone on one system. So the potential savings for this could be about $1 million per year community-wide. So keep in mind, this is not specific to COPD, and this is not specific to the hospital. This is community-wide savings that could be expected based on similar research that we've seen. So in total, we expect our interventions to cost about $748,000. Again, as we've shown, we're financially healthy. We can take on this because of the potential savings that we've seen here. We really think that the cost is worth the benefit that we would get from these.
So in conclusion, our interprofessional team has deemed it feasible by implementing our evidence-based recommendations that we're going to improve the transitions of care, the handout for these patients and families for COPD. Also, we're going to empower our patients to take control over their health with using the in-home monitoring device, and overall achieving the goal of reducing our 30-day COPD readmission rate from 25% to 20% within a year here at Odinia Community Hospital. Thank you.
Questions, whatever you have about specifically things that you had questions on, but we did want to make sure to give a special thanks to everyone that helped us out with this case competition. There was a lot of people involved, a lot of frantic emails and calls and everything, so we really, really appreciate that, and we just wanted to give a shout out to everyone, so thank you all in this room that have helped us.
And I didn't match people up with their status, but Scott, of course, is a graduate student in the medical school. Terri, graduate student in the School of Nursing, Kaci in Health Administration, and Sabrina in Public Health. All graduate students, all very busy with their other scholastic endeavors. But what a team. What questions do you have for them?
Did you say who the final, it's great to see Mizzou in the Final Four, by the way. Yes. Who were the Final Four?
Medical University of South Carolina, the University of Minnesota, and the University of New England.
Yeah.
Good
So,
job.
yeah, thank you.
We beat out some SEC teams. VCU. So VCU, Shaka Khan, the coach. Okay, so their coach for their team came up to us and was trying to do a head thing with us. We were sitting getting ready, and he's like, "So, Shaka Khan is our coach," and we were all like, "Yeah," and we all got our game faces on, and we're like, it was interesting. We met a lot of really neat people from different Texas Tech, their coach, and different people along the way. So.
So, great job, guys, and we're proud of you. You talked a lot about developing this order set for COPD. Did you talk any about how you will actually get all the docs to use that order set? Because we have a lot of order sets that are in absolutely pristine condition, that they're still in the wrapper, never having been used.
Yeah, we had a very similar question on the day of presentation, and I think my answer was, if we just need to stress the importance of these order sets for the patients, and how, yeah, we can save money, can make life easier, but in the end, it's all about our patients. And if we can improve the patient's outcomes, and if we can stress that to the physicians and the nurses and the rest of the staff, then that's going to be the way to make a difference. So I think that's what we talk about, at least in the presentation. And that's going to be tough to do, and it's always tough to make changes, but you got to start and just,
And so in addition, we also talked about the pay for performance and benchmarking, and as providers that we're going to be held to standards of each other, and that as we start to align and look at each other's peers and our pockets might be getting cut, that this is also not only just for the patients, but for our own healthy organization, we need to be astute to that. So
Those are great answers, and I think the theme here is that even once you developed a great product, you have to market that product, and you've got to market that internally to your providers and give them the reasons why it's in their patient's best interest and their best interest to make this disruptive change.
And we definitely didn't downplay the difficulty of that when we were asked that question. We understand that that's a very difficult step, and maybe the most difficult step in all of these interventions. So it's something that as a hospital we would have to really sit down and figure out the best way, obviously knowing our physicians, knowing our nurses, and how to best reach out to them.
Good.
What lessons have you learned from doing the CQI process, and how do you think that's going to benefit you in your future work?
Well, I had never heard of a causal map until 2 months ago, so the cause effect, nor had I ever done a fishbone. So for me, in nursing, I think this is wonderful. I'm going to be able to take this to other problems within my practice currently as a nurse practitioner and use this to diagram and drill down on specific patient factors and things that diagram it better, as well as to make the whole system work better. So this, I had no idea what I was going to be learning, and it's been really good.
So I know as a third-year resident in the family medicine department, we're required to do a quality improvement project. And so this, I think, will help me greatly prepare for that. But I think more importantly, when I'm practicing, out on my own, I think just improving my clinic and the flow and, just working with the nurses, the rest of the staff, I think this will go extremely far in helping me become more comfortable with all that. It's really complicated, but I think this is a good stepping stone to really help kind of start those foundations.
I might interject. On Wednesday, I was in Springfield meeting with one of our PT alums who's a supervisor with the Cox Medical Center, and he was on the first Clarion team, gold medal winners as well. He said it was probably one of the most valuable experiences he has as a student, and he's carried it all the way through his career now, working with Cox and doing similar kinds of analysis in a big health system like Cox. So he was very excited and was celebrating your victory with you.
Well, what was the hardest question you got?
There was one.
The air pollution.
Oh, yeah. They asked us about, and you would know because we've talked about this in our meetings, but they actually asked us, there was a lot that they gave us about air pollution and the quality of air and the fact that it's a very blue-collar community. There's a lot of factory workers, a lot of smoking, and they asked, why haven't you talked about that? And my response was, we do not want to boil the ocean, which I will thank Dr. Wakefield for. But basically, what we've discussed throughout this entire time is that we wanted to be very laser focused on our recommendations. We are a hospital, we are not a community, public health. We obviously want to help those aspects of it, but we're trying to focus on what as a hospital we can do specifically and what we can immediately impact our patients on. Obviously there's a lot of issues within this community, but as a hospital I think we just chose to really focus on the actual things that we can do to help our patients. And once we get this under control, then we can, branch out and see what we can do about the rest of the issues that are in the community.
They asked that several times.
Yeah. I think we were actually the only one that didn't. We're probably one of the only teams that didn't have anything about the external community issues. So.
Yeah, we also really emphasized that we were just focusing on a 1-year timeline. And so like Kaci said, down the road we would probably do more things, more community effort type programs to address those issues, but we really just wanted to focus on the 1-year timeline.
And we tried to stay true to our aim statement and just stay really focused that we were here to reduce 30-day readmissions, which that in all is going to help the entire health system and transitions of care, and as an interprofessional team, those were kind of our focus of working together.
Were there any other big differences between things that you guys proposed versus the other teams that you noticed?
Well, we weren't actually able to watch any of the other presentations because we made it to the final 4. So if you didn't get to the final round, you could sit in on the other presentations, but we weren't able to watch anybody's. Based on talking to people, I think we were probably the only team that didn't talk about the air pollution and quality and whatnot. I think we were the only team that had CliniSync, which is a very specific, real organization. I talked to someone there, so it's very real. I think we're the only people that add that. I think everyone else probably had a variation of what we did. I can't think of anything else that they didn't have, but I think it was the cause mapping. Yeah, no one had that because no one knew what that was, which is great. Get them right there.
I just want to comment, I thought it was brilliant that you brought in those, what's that, 2x2?
Oh, the matrix.
Yeah, you brought the interventions, the interventions of that 2x2 on your cause map, that was brilliant. And also the IOM aims and checking, those are great.
Yeah. I would like to take credit for that, but we had a lot of help with those, so those really great ideas from a lot of people, so.
I was wondering about the IOM criteria. You didn't have all the boxes checked.
This is a question we had as well.
I don't know, like efficiency wasn't checked related to one of the interventions. Yeah, the gold index.
We actually got that question specifically, and one of the things we said is that if you look at in-home monitoring, we don't have equitable check for that, and it's right here. And that's because this home buddy system has to be hooked up to a phone jack. It's thankfully not an internet thing. We can actually hook it into a phone jack, but there are going to be patients that we treat that just don't have that. They don't have even a phone jack to plug this into, so it really can't be totally equitable to all of the patients that we see, because we know that there are some patients that simply don't have the resources or don't have the lifestyle to be able to support some of these. And so that's why we really try to think specifically on each of these and really make a good case for not having some.
But what about the advocate as a nurse? We certainly want to be equitable in everything we do in nursing, so I just kind of wondered. You didn't check that box.
Oh, is this the updated slide? Well, no,
I think maybe part of that too was as part of the advocate responsibilities in that checklist, which I know you guys aren't able to view, but in that will include stuff like the in-home monitoring. And so, if the patient doesn't have a phone jack, she can't or he can't discuss, what this is all about, how you use it, the benefits and all that. So I think that's kind of what we were going.
And if time or resources are limited, that's the point of the LACE index, where obviously the goal with the discharge advocate is to see everyone that comes in with COPD, but if for some reason short on time, short on resources, or something like that, then they would use that LACE index to stratify patients and identify those with the highest risk and most need. And so at that point, it would no longer be a totally equitable system, although that is our goal.
And we couldn't check every single box either.
That might look a little strange if everything was
Did you consider giving the patients copies of the GOLD guidelines so they could help shape physician behavior the other way?
That's a good idea.
That's a good idea.
Yeah, we really hadn't considered that, but that is, because the discharge advocate is going to get a checklist of all those things, so the patient should as well. I think that's a great idea, actually.
Can you guys just talk about how you prepared and how much time you had to prepare, and did you mostly work individually or as a group, or how did that work?
So we were given the case, I think at the end of January-ish. And so we met, I think, once a week for a couple hours each each week for the first month and a half or so. That was like, meeting in a group. But on our own, we had to do our own research and be prepared to, get to the meeting so we could have stuff to discuss. And as time got closer, within the last month, we've kind of ramped up how often we meet. The past couple of weeks, we've had to meet like a couple times a week for 5 or 6 hours a night, and just gradually escalating how much time we're committed. And we just practice a whole bunch together, going through the presentation and critiquing each other, and faculty feedback was really helpful too.
I think then we practiced. We actually went over to Boone Hospital and presented to a group over there, which included a respiratory therapist and some nursing heads over there. So we got their viewpoint, and then we've presented here 2 or 3 times. So each time we got a little bit different feedback, which helped us to tweak this. And that was a really great experience. Everybody's opinion really helped us.
Any other questions? All right, well, thank you all for coming.